On the completion of this short video, you should be able to evaluate the portal venous system sonographically and with Doppler images to evaluate and help diagnose portal vein hypertension. We'll discuss some of the pathophysiology behind it and some of the most common portosystemic shunts that we will see in the presence of severe portal hypertension. So remember, we're going to have to evaluate the liver for chronic disease, evaluate for any sort of liver congestion, and think about this. It's not hard to discriminate those two, those causes of increased pulsatility. Tricuspid valve regurgitation and right-sided heart failure can be differentiated by analyzing the hepatic venous waveforms, and those are easily distinguished from cirrhosis because TR and coronary cardiac heart failure are going to manifest as very, dilated congestion, right? Dilated hepatic veins, IVC on grayscale, whereas cirrhosis, or remember the disease within the liver, is going to manifest or is going to show up as a compression and compress those hepatic veins. Remember those two different waveforms there that we're going to get from TR or highly pulsatile hepatic veins in heart failure. Otherwise, we're going to get the continuous flow in our hepatic veins with cirrhosis. Same thing when it comes to portal hypertension, just different causes. So we're going to have to evaluate the IVC for obstruction. So we're going to Doppler the main, right, left portal vein, and the splenic vein for direction. And then we need to look for any sort of portosystemic collaterals, gastric, pancreatic, any splenic or umbilical collaterals that may be present, decompressing the portal hypertension. So here the sonographer is probably in a right intercostal window, and they're just getting that main portal vein. Notice outside of the actual liver. We're not in the liver yet. We're distal to the porta hepatis, and they're just getting a nice AP measurement there with their calipers, and they're measuring here at 9.9 millimeters, which is completely within normal limits. Remember, anything greater than 13 millimeters may be found in patients with portal hypertension. Here's a good image of the main portal vein, hepatopisal flow, and you can see also normal flow in the coronary vein, which should be also integrated into the main portal vein. So remember that you're going to see retrograde flow in this coronary vein, which is also known as the left gastric vein. And that retrograde flow in that vessel is going to occur in 80 to 90% of portal hypertension cases. So that's a high number of cases. And like I said, again, that's why it's the most common. And if there was a high pressure and it was abnormal, it would be going away and it would be diverting some of the blood flow out of the main portal vein to decrease some of that pressure, and that can cause issues with some of our varices, gastric and esophageal varices via this flow. Some of our 2D findings for cirrhotic liver is going to be nodular, small. You're going to see a very enlarged caudate lobe, and you can kind of see in this upper image here, right? You see all this anechoic space right here surrounding the liver. That's fluid, so we have ascites here. So we're going to have fluid. Look how small this liver looks, a cirrhotic liver in this situation, and look at this very large dilated caudate lobe. So also, when we look at this, there's going to be some other sonographic findings with this. We talked about with the development of portal hypertension, that main portal vein diameter, that's initially going to increase because of that increasing portal venous pressure, right? But think about that. Eventually, once it gets more severe, right, not only is our flow going to slow down enough in our main portal vein, it's actually going to go hepatofugal in some severe cases. So in that case, remember, it's going to leave via collateral channels. It's going to actually, it may decrease eventually in more severe later stages of this disease because the decompression via those portal systemic collaterals. So again, think about this though, initially, as the pressure keeps increasing in that portal vein, the diameter is going to be greater than 13 millimeters, and that indicates portal hypertension with a high degree of specificity, 100%, but it does have a low sensitivity of 40%. So we're going to see reversed or hepatofugal flow in these. And again, we're going to see ascites, splenomegaly. And remember, those are findings that we typically see in portal hypertension, but those aren't remember those two though, ascites and splenomegaly, that's not diagnostic of portal hypertension. We just see it's associated with it. And it's not diagnostic because there's a long list of other etiologies that can cause, or diseases that can cause ascites and enlarged spleen, that beyond just portal hypertension. Remember, the most specific finding for portal hypertension that we can identify is the dilated portal venous system collaterals. That is highly specific to portal hypertension, because normally we can't visualize, we don't have any of these collateral systems. They're not dilated, they're not diverting flow unless we're in the pathological state of that portal hypertension, and we need to decompress the portal venous system and get that blood flow back into the central veins. Here's some ultrasound images as promised. So remember, we're going to see those gallbladder collaterals or varices there, kind of right there along the gallbladder wall, and you can kind of see those by the arrows here on this one. Remember, this is our gallbladder, and we're going to have those little collaterals or varices seen here, portal systemic collaterals there, as I previously mentioned. Those are usually shunts between the cystic vein branch of the portal vein in either any of the anterior abdominal wall veins or the portal vein branches within the liver to decompress the portal venous system. We have our gastric, esophageal, and gastric collaterals here in this image. Remember, we talked about how you're most commonly going to be able to find those located posterior to the left lobe of the liver. Here we are, left lobe of the liver, posterior, and you're going to see these large tortuous collateral branches here. Again, as we talked about in the previous diagram, you can kind of see how that blood flow is now leaving and shunting and coursing towards that area. Another good ultrasound image of left gastric collaterals there. You can see the liver adjacent and those gastric collateral varices that are dilated and visualized that are not normally present. And again, here's another example of those splenorenal collaterals, which are quite commonly seen as a quite common portal systemic collateral. And just kind of look at this, I'll kind of outline some things for you if I can, if it's helpful. We have the kidney here. We have the spleen. So remember, we're kind of on the left side of the body there, maybe left intercostal or just below the rib cage and imaging. So we're gonna have that spleen here, the kidney, the left kidney is kind of poking in, and then you're gonna see all these different collaterals developing or enlarged here that are not normally present in a normal physiological state. So again, that's that splenorenal collaterals that we're going to get there, and those are just those prominent varices we're going to see right at the splenic hilum, and we're going to have that enlarged left renal vein as we're taking the blood flow that way to decompress the portal venous system. So let's think about the normal splenic vein flow direction, right? And that's towards the portal splenic confluence. And you can see in this example or ultrasound, if we were just to show you this ultrasound, you would be able to identify the flow here, and you would see, remember, it's not inverted like it's supposed to be, and you'll notice this blood flow is away from the transducer, right, which is retrograde, which if you saw that would definitely clue something onto you that there's some sort of obstruction, right, because the blood flow needs to get somewhere, get back into the central venous system. So in this example kind of shows you that splenic vein retrograde in this situation heading back towards the spleen to help decompress that portal venous hypertension. Here's just a couple ultrasound images of a recanalized umbilical vein. This image A in transverse kind of shows that patent lumen that's coursing through ligament and teres. And you can kind of see in this image here, again, I am sorry, this is inverted and it should not be, right? Red should be towards blue away when we're doing abdominal vascular, but just pay attention and note that it is blue in this image, but it is going patofugal or out or away from the liver, right? And then they did a spectral waveform of that patent periumbilical vein. Here's just an ultrasound image demonstrating patofugal flow, right? Wrong direction out of the liver in the main portal vein. And as that goes this direction, it's going to dilate the collaterals as it tries to find a shunt to the systemic circulation. You can even see some free fluid here in this ultrasound image.